Good morning, ladies and gentlemen. My lecture today is from the section of aesthetic medicine from Rook's textbook of dermatology, and the chapter is 159. And this is regarding the aesthetic use of botulinum toxin. You will not find anything other than the Rook textbook of dermatology in this lecture. And I have tried to stick myself to whatever written in this chapter of Rook textbook of dermatology. Introduction. The botulinum neurotoxin is a neuromodulator that has proven efficacy for a variety of clinical conditions that result from neuromuscular hyperactivity that include muscle spasticity and blepharospasm. The approved aesthetic and dermatological indication for type A botulinum toxin include the treatment of hyperfunctional facial muscles that results in facial lines, which are, of course, called as the dynamic wrinkles, and the treatment of focal hyperhidrosis. So these are the two major indications in which we dermatologists use botulinum toxin. In 1992, it was observed that botulinum toxin type A was effective in reducing the muscle-induced forehead lines. This was followed by several studies confirming the efficacy of botulinum toxin A for the reduction of dynamic facial wrinkles. The botulinum toxin rapidly gained popularity during 1990s and early 21st century as a paradigm shift in the treatment of facial rejuvenation. So, for a long time, botulinum toxin remained the number one aesthetic treatment. But now this is replaced by fillers. In UK, an alternative type of botulinum toxin known as the Dysport, now designated as avobotulinum toxin A, was developed for similar indications. So this is a little bit about the history. We are going to discuss history more. Another approved indication of botulinum toxin A or onabotulinum toxin is the treatment of severe axillary sweating, which it is now recognized treatment option for severe localized hyperhidrosis, including palmar, plantar, and axillary hyperhidrosis. There are many types of botulinum toxin A that currently exist and are approved in European and USA market for aesthetic indications. In addition, botulinum toxin B has similar clinical responses to those of botulinum toxin A. The pharmaceutical terminology of some of the available neurotoxins. So these are the brand name or trade name, that is Botox, which contain onabotulinum toxin type A. Dysport contain avobotulinum toxin type A. Xeomin contain incobotulinum toxin type A. And Myoblock or Neuroblock contain remobotulinum toxin type A. Among them, the Botox or onabotulinum toxin type A is most frequently used throughout the world, including our countries. History and early research. Botulism was first described by a German physician, Justinus Kerner, in early 19th century, when he observed the outbreaks of food poisoning from contaminated sausages. He noted the neurological effects resulting in muscle paralysis and then death secondary to respiratory depression occur. In late 19th century, von Ermengem identified the bacterium causing botulism, which he named as the botulinum bacterium. This terminology was later on changed to Clostridium botulinum. In 1940, USA and UK developed botulinum toxin as a potential biological agent to be used during Second World War. Botulinum toxin A was purified and developed by Edward J. Shantz at the U.S. Biological Warfare Center, Fort Detrick, Maryland. This strain later on became known as the oculinum and then Botox or Ona botulinum toxin A. In UK, at the Porton-Down Biological Warfare Center, a different serotype of botulinum toxin A with similar characteristics known as Dysport was discovered, and now it is called as the abobotulinum toxin A. Medical use of onabotulinum toxin A. This was pioneered by an ophthalmologist, Alan Scott, in an attempt to discover a non-surgical treatment for strabismus. Scott had obtained toxin from Fort Detrick, and the studies initially studied the effects of toxin in ocular muscles of monkeys. In 1980s, Scott and colleagues proved that it was possible to improve strabismus by injecting botulinum toxin A into appropriate periocular muscles. The trade name of this injectable toxin became oculinum, and it was utilized for the treatment of strabismus, blepharospasm, and hemifacial spasm. A pharmaceutical company subsequently acquired oculinum and renamed it as Botox. History of clinical applications. It was noted during the treatment of strabismus that botulinum toxin A could reduce wrinkles in the glabellar region of the face. This observation was supported by Jean Cruther, an ophthalmologist, and her husband, Alistair Cruther, a dermatologist, in 1992. In 2002, the Food and Drug Administration approved onabotulinum toxin A for the treatment of glabellar lines. So this was the first indication for which FDA approved use of this toxin. An additional approved indications was in the treatment of severe axillary hyperhidrosis. So uses of botulinum toxin in medicine. Many other approved and non-approved indications of botulinum toxin in medicine are as follows. Conditions which are related to muscular hypertrophy, such as focal dystonia, blepharospasm, cervical dystonia, spasmodic dysphonia, writer's cramp, occupational cramps, hemifacial spasms, spasticity of the limbs in adult and children, strabismus, nystagmus, brotosis, facial tics, rigidity syndrome, and bruxism. So many conditions related to muscular hyperactivity. Then autonomic nervous system indications include focal hyperhidrosis, gustatory sweating, hyperlacrimation, and siluria. Then urological indications like overactive bladder, vaginismus, and urethrism. The gastrointestinal indication include anal fissures, outlet constipation, sphincter of OD dysfunction. The neurological applications include treatment for essential tremors, Parkinsonian tremors and spasticity, and pain control in migraine and focal muscle pain. The pharmacology and action of this neurotoxin. Clinical effects of botulinum toxin A and B results from pharmacological action at the neuromuscular junctions, blocking the release of acetylcholine at the neuronal endplate with subsequent inhibition of muscular contraction. The core molecule in botulinum toxin is 150 kilodalton protein with three distinct domains, which are the binding domain, the translocation domain, and the catalytic domain. Once inside the neuron, the catalytic domain binds to the specific intracellular protein, resulting in blockade of the neurotransmitter release. When acetylcholine is released less in the neurosynaptic junctions, then of course the action of muscles is also suppressed. The catalytic domain of botulinum toxin A binds to the intracellular SNAP25 protein, while botulinum toxin B binds to intracellular synaptic protein known as the synaptobrevin, which both of these prevent the exocytosis of acetylcholine from the synaptic vesicles, thus inhibiting the muscle contraction. After the limited duration of clinical effect, there is synthesis of new synaptic proteins and re-establishment of acetylcholine release with subsequent muscular activity. So that is the reason that that is the time when there is an end to the effect of botulinum toxin by establishment of new synaptic protein and re-establishment of acetylcholine release. So you can see here, these are the synaptic vesicles that should release this acetylcholine into the synaptic junction, neuromuscular junction. But by the presence of botulinum toxin, light chain and heavy chain, they they get attached to the synaptic proteins and inhibit the release of acetylcholine. So the receptors for botulinum toxin A is SNAP25 and botulinum toxin B is synaptobrevin. So this table from Rook shows some characteristics of botulinum toxin neurotoxin. Botulinum toxin A, Botox, which is botulinum toxin A, it is approved for all the facial lines and is also approved for hyperhidrosis and also approved for some medical conditions like cervical dystonia and blepharospasm. So it has the widest range of application. Dysport, which is also botulinum toxin A, it is approved for facial lines, but not approved for hyperhidrosis, and is approved for several cervical dystonias and blepharospasm. Xeomin, which is also botulinum toxin A, is approved for the facial lines, but is not approved for hyperhidrosis, and it is approved for cervical dystonias and blepharospasm. Then myoblock or neuroblock, which is botulinum toxin type B, it is not approved for facial lines and not approved for hyperhidrosis, but it is the improved indication for several spastic disorders like cervical dystonias and blepharospasm. Variation and equivalence. It's likely that the active light chain toxin in all proprietary botulinum toxin A product is identical, but variations in subsequent manufacturing process result in pharmacological differences between the final product. So all the botulinum toxin A types are not similar. They have some differences. These include differences in molecular weight, among other formulation. Botulinum toxin potency is estimated as unit of activity, and this varies among the different type A toxins and have been a subject of numerous comparative studies. So generally, on a botulinum toxin, 1 unit is equal to incobotulinum toxin 1.25 unit, which is Dysport, and which is Xeomin, and it is equal to 3 units of abobotulinum toxin A, which is Dysport. It must be stressed that it is best practice to consider each as a different drug and the dose of which will be individually determined. The clinical application of botulinum toxin for aesthetic indication. So the main target muscles for botulinum toxin A in face are with some common sites for these injection indicated here in the picture. So this include the frontalis muscle, the procerus, corrugators, orbicularis oculi, orbicularis oris, nasalis, then DAO, depressor anguli oris, the mentalis, and platysma. The botulinum toxin effect is individualized and tailored after careful assessment of these muscles. In reality, the first and most critical aspect of the cosmetic facial use of botulinum toxin injection is to learn how accurately you can examine the patient. Assessment should be made at rest and at the maximum muscle contraction. So always ask the patient to make the gestures or make the facial lines prominent. And in many cases, the facial asymmetry are found, and as a result, require a change from standard pattern of injection sites. So if you have discovered some asymmetry in the eyelid or eyebrow region or perioral region, then the units of botulinum toxin has to be changed. The upper face. Most of the clinical research studies addressing the cosmetic use of botulinum toxin for forehead rhytides have focused on dividing the various doses of botulinum toxin over 5 to 7 injection sites. In general, 1 or 2 injection sites into the process, and usually 2 each in corrugators, are the ideal injection site. So as far as the corrugators are concerned, we give botulinum toxin at the head as well as tail of the corrugator. The relevant injection sites and doses of various botulinum toxin A must be based on the detailed knowledge of facial anatomy of these muscles. The desired aesthetic outcome require appropriate training and experience. Glabellar area. All the 3 commercially available botulinum toxin A products were first approved for injection at the glabella. Brow elevation is produced mainly by frontalis. When the corrugators and procellaris muscle contract, the facial expression is that of anger or concern, since these muscles are responsible for medial eyebrow depression and ptosis. Contracting the corrugator muscles also result in 11 lines at the glabella, while the procellaris muscle create horizontal lines between the eyebrows and bridge of the nose. So usually these forehead lines are created at 90° at the action of the muscle contraction. Understanding the balance between the brow depressors and elevator muscle is key to a successful upper face rejuvenation. So you should understand that frontalis muscle is the only elevator of eyebrow, while the depressor of eyebrows in the medial and lateral eyebrows are different. The muscles at the glabella, that is corrugator and procellaris, are the depressor of the medial eyebrows. The treatment must be tailored according to the muscle contraction. You can see here, this is symmetrical contraction of corrugator and procellaris, so the number of units of botulinum toxin will be same. But once there is asymmetrical contraction, as you can see in this picture, the number of units of botulinum toxin vary at the different locations. Forehead, the frontalis muscle is employed to raise the eyebrow and to prevent the eyebrow ptosis. It creates forehead expression lines that express surprise or fear. The botulinum toxin treatment to mid and lateral forehead should be performed with relatively small amount of toxins compared with the glabellar area, because the frontalis is a flat muscle while the glabellar muscles are thick muscles. Overdose of toxin across the frontalis muscle inevitably results in undesirable brow ptosis. So the giving of high doses of botulinum toxin in frontalis will result definitely in brow ptosis. Complications in this area of injection are relatively rare, but occur as a result of wrong placement of toxin, resulting in either eyelid or brow ptosis or Mephisto eyebrows. The difference between male and female eyebrow shapes should also be considered. Male prefer a flatter brow, while the feminine brow is slightly arched mediolaterally. So in men, additional injection sites are at higher units can be used in lateral forehead to achieve a more masculine brow appearance, which you can see here. So these are the standard 5 lines to treat frontalis, but in men, we tend to give 2 to 3 units here as well to prevent the raising of the lateral eyebrow, which is what we want in female. The facial muscular size also vary between the sex, with increased strength and bulk in men. Therefore, higher doses per unit is given per site is given in men as compared to women. Crow feet, or the lateral canthal line and the periorbital lines radiate outwards from the lateral canthal areas. They are caused by contraction of the lateral fibers of orbicularis oculi muscle, and these lateral fibers are the depressor of lateral eyebrow. So by putting Botox here, you also prevent the downward movement of the lateral eyebrow. And since the frontalis fibers on the lateral side are not treated by botulinum toxin, these frontalis muscle will raise the lateral eyebrow, giving a more feminish look. So typically 2 to 4 injections are placed around the lateral canthal areas on each side, 1 to 2 centimeter lateral to the bony ocular rim. The selective reduction in activity of these muscles with botulinum toxin results in elevation of the lateral eyebrow, which is the desired outcome in women. The Mr. Spock or Mephisto eyebrow. Over elevation of the brow is usually undesirable, but can be corrected with injection of small doses of botulinum toxin into the lateral lower frontalis muscle. So now once the patient comes with this effect, we give 2 to 3 units at the middle of the forehead, just above the area point of maximum brow elevation. So this will bring these brow down. Infraorbital lines can also be reduced with very small, carefully placed doses of botulinum toxin. So you don't have to give more units here because if these fibers of orbicularis oculi are paralyzed, then the lymphatic drainage will be affected and may result in some under eye edema or puffiness. Mid phase. So there are several muscles in the mid phase that can be treated by botulinum toxin. One of the muscles is the nasalis muscle, which produce the bunny lines. So 3 to 4 units of botulinum toxin is given in this nasalis muscle to control these bunny lines. And to raise the nasal tip, we give few units, 3 to 4 units of botulinum toxin at the depressor septi muscle, which will raise this nasal tip. And similarly, for the gummy line, for the gummy smile, we gave 3 to 4 unit botulinum toxin at this point, which is also known as the Yancey point, which is the point where the three muscles are converging. That is the elevator labii superioris alicinasi, the elevator labii superioris, and zygomaticus minor muscles. At the lower face, the most frequently used site is the depressor anguli oris. By giving a few units of botulinum toxin, we will raise this ptosis of the angle of mouth, which is due to the action of DAO. And this gives a sad appearance. The point of injection is superficial and just along the mandibular border. Then these are the smoker's line, which are created in older patients. And the muscle responsible is the sphincter muscle of the oral cavity, that orbicularis oris. So 1 to 2 units are given into the smoker lines very carefully, just along the wet margin, injected into the lip. Similarly, 1 or 2 units are given at the lower lip as well. So you don't have to give more units because this will result in difficulty in closing the mouth. So the primary chin muscle is the mentalis muscle, and in later on, these muscle activity becomes non-symmetrical, resulting in unsighted dimpling. and puckering of the chin. And this result in additional depression of the angle of mouth. So this pabbling or puckering is treated by giving 2 to 3 units of botulinum toxin at 2 to 3 sites in the mentalis muscle, which will smoothen out these lines. Another prominent indication of lower face is injection of botulinum toxin at the masseter muscle. So the masseter is the main bulky muscle of mastication, and this has been successfully treated with botulinum toxin for aesthetic shaping. You can see this square jaw is converted into a beautiful oblong jaw by treating this masseter. Then coming to the neck. The main neck muscle is the platysma, and botulinum toxin is used to treat these platysmal bands. The platysmal vertical band tend to become more noticeable with age because of the loss of subcutaneous fat. The platysma tightens the skin of the neck and additionally produce depression of the lower face. So once we treat this platysmal band, the sagging appearance of lower face improves. The injection of botulinum toxin into platysmal band reduce the downward traction of the lateral face and also reduce the horizontal superficial necklines. The ethnic diversity of botulinum toxin. Botulinum toxin have been successfully used for aesthetic indications in different ethnic groups. One must respect the patient demand based on the beauty standards and ethical standards. Adverse events. The serious side effects from botulinum toxin for aesthetic indications are uncommon because the total dose utilized are low. The main cause of adverse events are the poor injection technique, inappropriate dose selection, and incorrect injection sites. Unfortunately, results and complications are usually fortunately, the undesirable results and complications are usually mild and transient because the botulinum toxin effect does not persist for more than 4 to 5 months. The poor results may be further improved by further injections into the compensatory muscles and in order to correct or minimize the unsatisfactory responses. It's imperative that practitioners understand the complexity of relevant muscle vectors for satisfactory and natural outcome. So in face, there are always uh, compensatory muscle or contradictory muscles. So there is brow elevator in form of frontalis and brow depressor in form of procerus, corrugator, and lateral fibers of orbicularis oculi. Similarly, if we come to the region of mouth, there are several elevators of the mouth, which include the levator labii superioris alicinasi, levator labii superioris, the zygomaticus major, zygomaticus minor, levator anguli oris. And similarly, there are many depressor of the mouth like depressor anguli oris, depressor labialis, and then the mentalis. So there are always compensatory muscles. So we have to understand these muscle movement to give better results with botulinum toxin. The summary of reported side effects following aesthetic treatment with botulinum toxin. Most frequently, you can cause bruising, particularly in periorbital areas. Lower eyelid edema, which develops if you give more units of botulinum toxin in the lower eyelids. Brow-ptosis and lower face asymmetry. Less frequent is the headache and flu syndromes. Much less frequent is diplopia. Diplopia develops if you give botulinum toxin too close to the lateral canthus and it seeps into the lateral rectus muscle, resulting in diplopia. Distal muscle weakness like dysarthria with platysmal injection. So more units are given into the platysma, which goes down into the muscles of phonation. Then hypersensitivity reaction, dry mouth and dry eyes. Mitigation of bruising risk involves avoidance of injection in those patients which are taking medication or supplements which cause blood to clot less, like aspirin, non-steroidal anti-inflammatory, the anticoagulant drugs, and oral omega-3 and omega-6 fish oil supplements, as well as excessive ingestion of oily fish and alcohol. So all these factors make the blood thinner and less capable of clotting. So this increases chances of bruising. And these drugs should be stopped whenever you are injecting in a face. The local skin swelling at the injection site is visible on the forehead and gets clear in few hours. Post-inflammatory hyperpigmentation is at higher risk in darker skin phototypes, followed by bruising. So if bruising develops in pigmented skin, it may result in PIH. Another common side effect is pain on injection. Rarely patients have persistent headache or pain lasting for several days. The possible reason of injection close to the subcutaneous nerve. Other side effects like eyebrow and lower eyelid ptosis usually result from inaccurate placement of botulinum toxin and commonly result from injection of too high a dose into the lower lateral or mediolateral forehead. So this type of injection should be avoided. The resultant diffusion of toxin into the elevator muscle of eye or lower fibers of frontalis muscle results in ptosis. Lower facial or lateral lip ptosis. It can also result from injection in the lower periocular area, too lateral and too low, encroaching on the malar. So if the Botox is given at the lower malar area while treating the crow feet, these units may enter into the zygomaticus minor or major muscles, resulting in the lid ptosis. Because the elevators are paralyzed, so the corner of the mouth will be pulled downward, resulting in lip ptosis. Facial asymmetry results from unequal dosing of toxins and other complications, which is a considerable concern. Less common side effects include paresthesias, diplopia, dry eyes, dysphagia, and dysarthria. They are generally due to inappropriate high dose of toxin injected into the periocular muscles or muscles of larynx and pharynx. So a cautious, conservative approach is best, particularly for inexperienced practitioners. So for inexperienced practitioners, you should start with giving low dose, and you may call the patients after 7 to 10 days to give more if the results are not appropriate. The special considerations. The incidence of undesirable side effect is generally higher in older patients, possibly because of increased spread of toxin into the atrophic muscle. The muscle are atrophic. Furthermore, in older patients with more severe extrinsic and intrinsic facial aging, it is unlikely that use of botulinum toxin alone will be sufficient to result in acceptable outcomes, so we need combined treatment. So botulinum toxin use in perioral area should be used with caution for professionals, wind musicians like those using trumpets, and singers, where suitable alteration in fine muscular activity will have significant impacts. Similarly, there is a theoretical risk for treating palmar hyperhidrosis in those which require very fine muscular control in hands, like for typing and for jewelers and musicians. Contraindications of botulinum toxin. Patient with history of myasthenia gravis or other neuromuscular disorders should not be given botulinum toxin. Pregnancy and breastfeeding are relative contraindications. Manufacturer advice is to avoid. Some oral medication and supplement like oral erythromycin and zinc supplements tend to increase the therapeutic response to botulinum toxin. Acquired resistance to botulinum toxin. It's a rare problem, which is the development of acquired resistance. So with subsequent botulinum toxin injections, the effect becomes less and less, and the effect wears off quickly. This does not appear to be related in all cases to presence of antibodies, as resistance has been noted in patients where antibodies remain undetected. So one of the theory is the formation of antibodies, but other causes as well. So botulinum toxin A resistance occur. Botulinum toxin B can be effective as it acts via different synaptic protein, as I've already mentioned before. Then the combined treatment. Combined treatment may be required for older patients with skin and muscular and fat atrophies, and these include use of fillers, radiofrequency devices, microneedling radiofrequency, PRP, and skin boosters for rejuvenation, particularly around the mouth. The future of botulinum toxin in development. The development of topical application of botulinum toxin A was initially encouraging after research showed efficacy against hyperhidrosis and superficial facial lines. So further research did not confirm these studies, and yet there is no topical botulinum toxin available in the market. The number of new type A toxins are being developed and waiting for regulatory approval in US and UK. This include parabotulinum toxin A, the deoxybotulinum toxin A, and len-botulinum toxin A, as well as liquid type of botulinum toxin ABO. There another botulinum toxin type E is more rapid onset and shorter duration than type A toxin. The clinical use is yet to be determined. So these are all the future prospects. So this brings me to end of this talk. I hope this would benefit you, and especially all those candidates who are appearing in the exam, because now we expect a few MCQs from this section as well. Thank you very much for patient listening, and see you next time with another edition of my lectures. Goodbye and have a good day.